It is my pleasure to introduce Dr. Mary Charles Haigler. Dr. Haigler provides conservative and minimally invasive care for orofacial pain patients at the Carolinas Center for Oral and Facial Surgery. Dr. Haigler is co-director of the clinical rotation in orofacial pain for the Medical University of South Carolina, and she is a presenter for the general practice residency at Prisma Health, as well as speaking at many other continuing education programs. She enjoys speaking on the topics of orofacial pain and TMD, and you're going to enjoy hearing from her. So please welcome Dr. Haigler.
Well, I've been sitting in this morning just because I kind of wanted to see what you've already learned. So there are a couple of things that you're going to get in repeat, but we'll try to keep it just building on and not backing up. So my topics this morning were muscular disorders as well as interarticular disorders. So we're going to start with the muscular disorders. I know that they've already done a little bit of anatomy for you. I just kind of wanted to back up again, and I want you to notice the direction that those muscle fibers are running. So that's one thing that Tom was talking about earlier. And what we know is that when we are palpating different muscles, when we're looking at those disorders, you want to go across, as he said, perpendicular to the muscle fibers. The reason for this is that's where you can feel those top bands better. If you're running parallel to the muscle fibers, those little top bands are just going to kind of melt away in your fingertips. If you go across them, you're going to feel them better, and that's going to help you to find where some of those places that you want to linger and see if there's pain there. If you notice, as he was pointing out before, the masseter itself, there's actually a couple of bellies of the masseter, so you can kind of palpate some this direction, and then a couple of them are more this direction. So you want to palpate in both ways. So you want to palpate across those muscles as well as across in this area. When you go up to the temporalis, you'll notice there. I usually walk around, but I know my microphone's here, so I'm just going to try using the pointer. But the temporalis has muscle fibers running this way, and then as you move a little bit towards the middle, they run a little bit more obliquely. And then as you move more towards the posterior, they're almost horizontal. So you have to change the direction of your palpation as you go into each of those areas, okay? So that's one thing to notice. And as they've already mentioned, lateral pterygoid, I can't palpate it either. I know some people swear they can, but as I think it was Sherwin said earlier this morning, you're going to be pushing on so many other things, it's really hard to tell exactly what is feeling the discomfort. So, again, you don't want to let them protrude so far that you're actually manipulating the joint too much, but you do want to put resistance and have them try to protrude against that to feel the resistance of the muscles there. I think that's all I wanted to show you on this slide. As we move on to our next slide, so they also mentioned we call them the auxiliary muscles of the head and neck. So we're looking at sternocleidomastoid, anterior digastric, posterior digastric. So again, sternocleidomastoid is right here. It gets its name because it's coming from the sternum, the clavicle, those are the origin. Insertion is up at the mastoid process. And as he mentioned, if this muscle contracts, it actually rotates the head away from that side. So as my left contracts, I rotate right. So if you're having trouble finding it, I know they said it's pretty easy to find, and it is in most people, but if someone has a little extra mass to them, a little extra padding possibly, it's a little harder to find. But if you have them activate the muscle, then you can find it a little bit easier. So that might be helpful to you. And as they mentioned before, with the anterior digastric and the posterior digastric, there's a lot of soft tissue there, so those can tend to move away from you. But again, you're using, you can use pressure for the anterior digastric both in the floor of the mouth and pushing up. Posterior, it's going to kind of run away from you, but we're going to try our best to palpate that area as well. I also like they were saying before, I don't tend to go all the way down to the rhomboids, but here's where Tom was mentioning rhomboids are down a little bit lower. I do focus a lot on this superior portion of the trapezius. And as they were mentioning there, you can actually palpate that with, instead of pushing down on it, you can use that pincer grasp. So we use that in the trapezius, and I follow it all the way up along the back of the neck as well, and that kind of helps us to feel those really taut areas. And as they mentioned, a lot of people, you'll have people come in and tell you, I hold all my tension here, and they really do. You can see how they hold their shoulders a little bit more tense, how they're posturing a little bit differently. Also, that posterior portion and the sternocleidomastoid get activated a lot these days because of people that are sitting at computers. If you think about it, with the head forward position, that's putting a lot of weight on those muscles trying to keep the head from just collapsing all the way forward. So you're actually increasing the load by sitting forward like this. And a lot of general dentists, which I know we have a lot of general dentists in this room, you're sitting forward like that. I know our ergonomics tell us to sit up with our telescoping lenses, but a lot of people do tend to tilt a little bit. So you may actually have some of that pain as well. So those are things to look at. Now I'm going to kind of back up, and in this we're going to talk more about the different types of disorders that people can have with their muscles. Now, not all of these are going to be muscle disorders that you're going to diagnose and treat. I just like you to have an idea of what's out there and when you might need to refer out as well. We're going to start with one that is going to be pretty common to you, and that's bruxism. So everybody knows about bruxism. Patients will tell you, I clench, I grind, or they'll tell you, I don't clench and grind, and you have reason to believe that they might. Bruxism, though, is really centrally mediated parafunction, especially sleep-disordered bruxism. So it's not because of an external factor. Even daytime, if you're bruxing, a lot of times it has to do with the stress that you're under. So stress it kind of amplifies the amount of clenching or bruxism that people do. So bruxism in general is characterized by grinding, clenching, and as Tom mentioned, it can also be bracing or even thrusting of the mandible. Like some people aren't really clenching down, but they hold their jaw forward. They hold that tension there. Sometimes this can be protective. You'll see that some people might brace when they're running to try to hold their airways open. You'll notice that some people just brace because of stress. So it kind of depends on the person, how they are posturing. Daytime bruxism is considered a somatoform disorder, so disorder of the body. If it's sleep bruxism, though, it's actually more of a sleep disorder. It's a sleep-related movement disorder, just like not restless legs, but moving your legs at night. Those types of things are actually sleep disorders. So it's not something that you can stop by having perfect occlusion or by having the perfect night guard. It's actually a disorder that the patient has that you can help to manage risks of, okay? So the reason it's called parafunction is it's not part of speech or chewing, so there's no real good reason for it. There's no functional benefit for us to clench our teeth or hold things in a certain way. It's more of a disorder, okay? Now, there are a lot of signs and symptoms of bruxism. Again, these are not causes of bruxism, but they're little risk factors that you can point out to patients or adverse effects of bruxism. So, wear facets. You've seen patients that have flat spots on their teeth that is not just normal chewing would cause those. Some people have significant attrition of their teeth or significant reduction of cusp height from their teeth because of how much they brux. Some it's a little bit less. But if you appreciate that there are those wear facets, then that kind of helps you to see that there's probably some other movement. Now, I like to pause here and say, I don't tell people, if they've told me I don't grind my teeth, I don't look at their wear facets and say, yes, you do. You don't want to start up an argument with the patient. You can just let them know, I see these, and I wonder what that could be telling us, you know? Kind of open the conversation. Let them ask you, where do you think these are coming from? And then you can tell them, well, sometimes when you have these, it's because your teeth are rubbing together. And let them draw their own conclusions. Cracked or chipped, fractured teeth can also be because of the forces of grinding or clenching. Now, some people are going to have more risk. Of course, if somebody has caries and it's actually a cavitation of caries, then that's not necessarily because of clenching and grinding. I'm talking about the healthier looking teeth that have crack lines in them, or even if they do have restorations and you're cracking away from those restorations. Even craze lines, those can all be signs of forces on the teeth that are causing this disruption to the natural crystallization of the teeth. Abfractions. Now, abfractions can be, it depends on the patient as to how severe they are and as to how much of that could be also related to toothbrush abrasion and things like that. But what we notice is that if someone is having their teeth clenched together and there's even the microscopic little movement of the teeth as you grind, that can weaken the crystallization right above the gum line, right above where that little micro trauma is taking place. Then when they brush, it's more likely that they're going to get that groove there. So a lot of times people with abfractions are also clenching and grinding. Mobility of teeth, obviously, if you're putting a lot of force side to side, you might notice there's some fremitus of mandibular anteriors or even maxillary anteriors if there's somebody that really bruxes forward especially. So that little bit of mobility can be an indication of those stressors as well. Of course, if they have periodontal disease, we're not going to say it's just because of bruxism, but it's something to keep in mind. Myalgia or muscle pain. So what's interesting is a lot of people that have the most wear of their teeth, they may not be the ones that have the most muscle pain. We kind of find that it's like if you're working out all the time. If you're used to working out all the time and you go work out again, you're not necessarily going to be as sore as somebody that hasn't worked out that much, then goes, lifts a bunch of weights, now you're sore. So somebody that is not a consistent bruxer may be more sore when they start bruxing than someone that has been bruxing consistently, okay? So it doesn't necessarily mean that they're grinding their teeth all night when they start to have muscle soreness and things like that. It can also lead to intercapsular changes as well, and we'll talk about that a little bit. One of those changes can be, so I always like to talk with my hands too, so y'all have to excuse me for this. But, so let's pretend these are your teeth, and they're interdigitating, okay? Now, if they interdigitate, and I'm clenching down, and then I grind sideways, there's a lot of lateral force to that, okay? You can do it yourself. You can see. So that, in and of itself, can stretch ligaments, can start to lead to muscle pain or joint pain. It can lead to the elongation of the collateral ligaments of the disc that hold it in place so that you can start having more joint noise. Okay? Now, if we have, and this is where it does benefit to have a device like a orthotic or a splint, is if you have something smooth and you clench down on that and you grind, I'm pushing down just as hard, but I'm not making that same force side to side. Okay? So that's something, I'm not stopping them from clenching and grinding. I'm just helping to protect them from injuring themselves. Okay? So those are the main signs and symptoms of bruxism. there's a difference, as I mentioned before, between sleep and daytime bruxism. And it's thought that it could be from a different etiology as well. There is some relationship that is seen in some cases between bruxism and obstructive sleep apnea. And what we notice is that it's actually the microarousals from sleep that are related to autonomic activity. So as you're coming out of your different stages of sleep and you're changing sleep, that may be a time when you brux more. It's not that the apnea is causing you to brux, but it's causing you to shift your sleepiness, okay? Or shift your stage of sleep, excuse me. So it's not clear. You can't look at studies and say, this is causing this is causing that. So you can't say because somebody bruxes, they therefore have sleep apnea. But you can wonder if one is also related to the other. Are they exacerbating each other? Things like that, okay? Now, there's also sleep-related bruxism can be related to medications and substances. So you all have probably heard that like SSRIs or SNRIs can be more linked to bruxism. So, but I would not recommend going and telling your patient you have to get off of your antidepressant because you're grinding your teeth. We have to look at their overall health, and we have to look at risks versus benefits. It's something that they could possibly talk to their physician about is there a different medication that might work better for me, or do we need to add another medication that might help to reduce that likelihood? But there is a little bit of a relationship there. So if they suddenly start having more symptoms and they've just added a medication, that could be a reason why, okay? But then there's also daytime bruxism can be related to people with different psychiatric disorders. So now, not everybody that bruxes in the daytime is going to have a psychiatric disorder, but if someone does have a neurologic change or a psychiatric disorder, they may be at greater risk for daytime bruxism. Okay? Now, if I move on to myalgia. So myalgia is basically muscle pain. So it's a symptom of a multitude of different things. So myalgia itself is not necessarily telling you the etiology or what is causing the muscle pain. It could be from clenching, it could be from grinding, or it could be from something else. So we still have to investigate a little bit more to figure out why are they having this muscle pain. If we look into that a little bit more, I wanted to back up. They mentioned pain earlier, right? We're talking about orofacial pain. But I haven't heard anybody say so far, what is pain? Does anybody in the room want to venture a guess as to what pain is? Anybody feeling brave? Okay, go for it.
It's a neurologic and psychologic response to the stimulus.
He said it's neurologic and psychologic response to the stimulus. Very, very good. So it is both a sensory and emotional experience. Exactly. So just the nociceptors telling you that there's something going on does not necessarily mean that there's pain. Somebody might have that nociceptive input and not call it pain. Somebody else might have a lot less sensation there, but really experience pain because they have an emotional tie to it. One example that somebody gave me one time that I like to use is, let's say somebody has a fractured arm, okay? Now, we would assume that's painful, but the pain may be worse in one situation than the other. Let's say one person was just playing in the tournament, the grand championship for their baseball team. And they slid into home, and they got the winning run. They broke their arm, but they're on an adrenaline high because they just helped their team achieve this championship. Now, somebody else got attacked by somebody and their arm is broken, and it was a very traumatic experience. The pain is likely to be more in the attacked person than it is in the grand championship person. So it's just the emotional impact of it can really make a difference as well. Does that make sense to people? Okay. All right. Now, if we go on to muscle spasms. So muscle spasms can be because of an underlying disease. It can also be because of low magnesium or low potassium. Sometimes it can be from using a muscle too much. Sometimes it can be from not using it enough. Like if you're sitting still for too long and your muscle's in that same position, it just might try to cramp up on you. So a muscle spasm is, it's tight, you can stretch it out, and then that usually helps to relieve it, okay? Now, we can contrast that with contracture. So contracture is actually a decrease in the range of motion, and that is either because of the soft tissues are basically foreshortened to the point that you can't stretch them back out, okay? So sometimes that can be because of a previous injury where now there's basically scar tissue there that is limiting the amount of movement. Sometimes there is deformity from an arthritic condition that's making it more likely. Sometimes it's a disease like Parkinson's can lead to this. I actually have 2 patients currently that have contracture, and it's because of post-radiation fibrosis. So the hard thing is with a muscle spasm or with contraction of the muscle, you can usually stretch it, like how I think Tom was showing you the passive stretch of the, just to increase range of motion, see if there's a soft end feel or a hard end feel. With contracture, you can't stretch them, but it's not because of a hard tissue change. It's because that the soft tissue is so tight that it just won't go, okay? So there's a little bit of a difference there. And that can develop over time. So the injury, like for radiation, it may have happened for one of my patients. It's been a year or 2 ago, and the contracture is just continuing to develop, continuing to scar down. And the more you the more you don't use it, the more it's going to constrict down. You also see some contracture with Sjogren's patients as well. So if you think about, scleroderma is what I meant to say. With scleroderma, the tissues kind of fibrose as well, and so they can have limited range of motion. So what you want to do is encourage them to continually keep moving, keep stretching, so that they don't lose the ability to. Okay? Hypertrophy. So hypertrophy is another common thing that we see. Sometimes it is related to bruxism. Sometimes we don't really know the reason, but the good clenching, you've probably seen people with bulkier masseters that don't really fit the rest of the shape of their face. You probably have some patients that come in and they want Botox because they've heard it can help reshape their face. And honestly, it can because of decreasing that clenching ability of the muscles. So it's the increase in size of the individual fibers. It's not actually more fibers or a more muscle. It's actually just bulking up that muscle. Okay? And it can happen in more than one muscle. Some people have it both in their temporalis and in their masseters. A lot of times it's more masseters than temporalis, but it can be, and it's not just those muscles. Those are just the most commonly affected ones. So those are just the usual everyday things. Now, a couple of the guys have already talked a little bit about trigger points and referral. I wanted to kind of break it down a little bit more and really explain what the trigger points are and and I know they've talked a little bit about how to palpate and things like that, but I want to kind of tell you the reason why that works, okay? So, as I mentioned, a trigger point is basically, it's an area in the muscle where sensory nerves are approaching that motor end plate. And what you're actually feeling is when that muscle moves, it's stimulating those sensory nerves, and that's where the pain is coming from. So it can be anywhere from 2 millimeters to a centimeter area is where the trigger point starts from. So that's why when they're having you palpate, two things. One is you have to use 1 or 2 fingers, because if you're using a whole hand, you're not close enough to that small size. So it's harder to locate exactly where it is. So the smaller amount of force that you're putting helps you to localize it a little bit better. Now, the other thing is that when you squeeze it, or when the muscle's activated, or when you put pressure on it, you're, of course, stimulating those fibers, those sensory fibers. And so that's when you can help to find where it refers to. Now, and for it to be a trigger point with referral, what you're looking at is there's pain in the place that you're pushing, but there's also pain somewhere else. And they may be it looks like a totally different area. So, so I'll explain a little bit more about why that's the case. Now, what we haven't talked about is how do they form. So, to put it simply, basically you're contracting your muscles. Now, what I'll show you is, it's probably hard for y'all to see in the back, but my skin kind of has a little bit of a pinkish tint, right? And it's because you can see blood in there. If I squeeze my hand really tight and hold it there, and then I open it up, there's going to be areas that it's whiter, right? And why is that? Because I decreased blood flow. I caused a little bit of ischemia there. So if someone is clenching their teeth so tight, or holding a posture so tight, even though we don't see the muscle blanching, they're decreasing blood flow. So if you decrease blood flow for long enough, frequently enough, what you're allowing to happen is metabolic byproducts are building up. Or if there is inflammation, inflammatory mediators are building up. We're not getting the nutrients. We're not getting the blood supply. We're not getting the oxygenation. And we're building up byproducts and not getting nutrients. So what that does is it sensitizes those sensory nerves. And then what happens is they start sending signals at inappropriate times. So it's not pain anymore. Now, or it's not pain from a nociceptive, it's pain from proprioception, possibly. So now we're getting pain where we shouldn't have pain. And then sometimes there's even spontaneous pain if it's been going on long enough. So you're not even moving the muscle anymore and it's painful just because of those byproducts, those metabolic byproducts being in the tissues. Now, with that going on long enough where those nerves are still sending the signal that there's pain here, there's pain here, there's pain here, it can start to cause what's called central sensitization. And central sensitization is back in the spinal nucleus of 5 and back in the upper spinal column, spinal cord, where they were talking about all those other nerves come into play. So that's how, what happens is the second order neuron then becomes sensitized as well. So it gets confused as to where the signal was originally coming from. And it's starting to think that everything is pain. Okay? So, again, that goes back to how do we find them? Now, I know we've heard this a few times, but we'll just go over it one more time. So fingertip pressure, you're going to move your finger. You're actually pushing hard enough, as he said, for your fingertip to kind of blanch. That's always a good landmark. And then you're actually moving the skin over the muscle. If you're just moving your finger over the skin, you are not pushing hard enough, okay? So you're pushing down, you're moving it across the muscle. Now, when you find where the patient feels some pain or where you feel a taut band, stay there. As they both said, it's usually around 5 seconds. Longer is better. You're not going to create a problem there if there wasn't one. You're not going to create a referral pattern from your palpation, okay? So, but you want to be able to find it. So the longer you hold it, the better it is. 5 seconds is a good ballpark. And then you ask them about referral, because they may not tell you if you don't ask them. But if you ask them and then they say, oh, yeah, I do have, but I wouldn't say, do you have pain in your chief sources, to say, do you feel it just where I'm pushing, or do you feel it anywhere else? And they'll kind of expand on that. And as he said, you also want to ask them, is this a familiar pain or is it a new pain? Because if it's not what they came for, you still have to keep looking, right? So in order to diagnose it, the patient has a regional pain complaint. There is an identification of that palpable taut band. There's pain on palpating there. And then the palpation also elicits the referred pain. Usually there's some restriction to their motion because they don't want to move that muscle. And it reproduces the clinical complaint, the chief complaint. Sometimes when you go across that taut band, it may cause a little twitch of a muscle, even not right beside it. It could be elsewhere, but you can see like a little twitch response. That's also a good indication. And if you were able to get that muscle stretched, either with spray and stretch, so you get it nice and cold and stretch, or using a little local anesthetic, and then if that alleviates the pain, then that is confirmation that that is the source of the pain, okay? Now this kind of shows you a little bit about what we're talking about as to why these referral patterns can happen. So if we're looking here, so the trigeminal nerve comes into the brainstem, but then it comes down into the spinal cord to the spinal nucleus of 5. That's where it meets the second order neuron. Now, if we look, we also have spinal nerves coming in here. We also have nuclei of some of our other cranial nerves very closely associated to that area. So where they meet the second order neuron, it might be shared by another nerve as well. Okay? So as it sends its message on up towards the thalamus, on up towards the cortex, your brain is basically confused as to where did it come from? Was it, and just to make it a little bit, say I'm one nerve. This is my axon heading on up. Here are my dendrites here. So let's say this one comes from the masseter. This foot over here comes from the temporalis. Or let's say it's actually coming from a maxillary tooth. Okay? Now, I might get confused if I'm a second order neuron. Did that pain come from my masseter or did it come from the tooth? Because they both came to me and I'm sending the signal on. Does that make any sense? Okay. So as you can see, you can have that convergence of information that then gets a little confusing for your nerves when they're overly sensitized. So there are some patterns that are very well known as to where those are likely going to refer to. Okay? So one, for instance, is if we're looking at the medial pterygoid. So that's kind of hard to palpate in all the regions of it, but you can palpate a good bit of it. You just have to risk gagging the patient sometimes. But if that X is where I'm pushing, all these little red dots are where the patient could feel referred pain. The more concentrated they are, that's where more people felt it, okay? So you can have pain up near the joint from the medial pterygoid. The lateral pterygoid can make the ear hurt, and it can also make the maxilla hurt, like up in your maxillary sinuses. Posterior digastric kind of just follows this band. Anterior digastric What I like to make people aware of, and I don't know about y'all, but when I was a general dentist, I didn't love doing root canals on little tiny mandibular anteriors. They're just tiny. And you don't really want to have to do one on somebody that they don't need it, right? Everybody agrees with that. So in this case, if I'm putting pressure here and it causes pain in my tooth, then it's possible that the patient that came in with pain in their tooth was really having pain in the muscle. Does that make sense? So you don't want to treat the tooth if the pain came from somewhere else. So that's where these are important. So if you don't see any problem with a tooth and the patient's having pain there, that's where you could back up and look at muscles and see if anything's being referred. The next area that we look at is, they mentioned semispinalis capitis. So that one can refer up towards the back of the head. It can be that hat band that a lot of people feel when they have like a tension type headache or things like that. So it can be from muscles sending that signal. The splenius cervicis can also refer up to behind the eye. Ones that I want to show you, though, that might be more in your day-to-day are trapezius. You know, we all mentioned trapezius being one that we palpate. And it seems like, why in the world would you palpate trapezius when we're looking at face pain? But look at where trapezius refers to. It can refer right back here. Have you ever had patients come in and say that their wisdom teeth hurt, and you're like, well, I don't really see anything wrong there. But it could be that it's actually a referral of muscle pain. Also, the sternocleidomastoid, I find this to be one of the most interesting, because if you notice on all these other ones, and you may not have noticed because it's only showing you one side of the patient, but in all of the other ones, your X and your red marks are on the same side of the patient. So it stays ipsilateral, right? In the sternocleidomastoid, it can, especially the clavicular belly of the sternocleidomastoid, it can refer across the midline. So I may have pain in my sternocleidomastoid or a trigger point in my sternocleidomastoid and feel pain over here. Okay? So that's one that I find interesting. You may also feel it in your chin. You also may feel it in the submandibular region or in the maxillary sinuses. Now, if you go to masseter, look at these. These are teeth that are aching. So the masseter is where the stimulus is. That's X's, but the teeth are red. So you can have a toothache because of your masseter hurting, okay? And you can have the ear hurt, which a lot of us know that the TMJ itself can refer pain to the ear, but so can the masseter, okay? And then look at this. Any of the maxillary teeth can have pain from the temporalis. So anywhere that you push up in the temporalis, it could be referring to any of your maxillary teeth. So I know a lot of people are aware that sometimes sinus pressure and sinus pain can refer to teeth, but also muscle pain can. So that's the point of these. So I wanted to show you a little example. So one patient came in with a limited range of motion. This is actually one of my contracture patients. He'd had radiation just 4 months ago. He states that he has right-sided pain. He sees a physical therapist. When he does the exercises, he says he has pain afterwards. So I don't know if he's listening as well. I mean, I know you can get some pain, but he's trying, but he's still having pain. He was told that he's taking too much acetaminophen, so his primary care physician gave him gabapentin and hydrocodone to try to help him control the pain. He doesn't know if the headaches are from the jaw pain or neck pain or what. His salivary flow is also affected. That's a side note, but as Dr. Weber showed you, we kind of go over the whole history to see what all is related. Maxillary teeth were extracted over 5 years ago, but the mandibular teeth were extracted just before radiation. But basically, when he's having pain on that right side, it radiates up towards the right side of the head. And he's telling me that he has a stabbing headache, and it's a painful headache every day, all day, for months now. Okay? He also has some neck pain and things like that, but his headache pain can get up to a 9 out of 10. So it's very significant. It's also leading to other things like he'll feel dizzy or have double vision with the headache. Sometimes a hot shower makes him feel better, but chewing, opening his mouth, doing his exercises recommended by his physical therapist are exacerbating the pain. He has seen ENT. He's done a CT scan. They've done a CT scan of his head to make sure there wasn't any other reason for this headache that's lingering like this. And then he actually has another CT scan of his neck scheduled, and he's had PET scans, and everything's clear from his cancer. But what we found out, I don't want to take all your time on the one case, but he does have ear congestion symptoms. He's not a very good historian. He doesn't really remember what cancer he had, just where it was. It was in the tonsils and lymph nodes on the right side. But when we did the exam, I'm going to kind of skip through. Tom already mentioned the PSQ-4, which is the anxiety depression indicator. Again, we don't use it to start treating them, but maybe to send a referral if they need some support. Sleepiness scale, again, poor sleep can exacerbate pain. I looked at his medications, but look here. Once we get to the actual palpations, I use a different scale than Tom does. I don't use 0 through 3. I use the same 0 through 10. So they just tell me exactly where their pain is on different palpations. But when I got to the temporal tendon, or the insertion of the temporalis to the coronoid process, that was a 5 or 6. Okay? So what we did, he didn't have any, he couldn't hear finger rubs quite as well on the right side either. Sometimes there can be that change as well. And then he does have painful neck movements. He does have a restricted range of motion, only 27 millimeters comfort. Active was 30. Tried passive, it was 31, so not much more. But looking at CBCT, I noted his maxillary sinuses had obstruction, but his joints actually had adequate joint space, good coronal sagittal views. What I wanted to get to is the diagnosis is basically that there's tendinitis at the temporal tendon at the insertion there. So what we ended up doing, I was also helping with a couple other things like Salogen for dry mouth and things like that. But I injected the temporal tendon with xylocaine and a little bit of Kenalog. And then what we noticed is that right after that, there was immediate relief of the headache. So numbing the trigger point takes away the headache that had been there for 4 months. Okay? So then he's able to start stretching and start trying to improve his range of motion and try to keep it moving so that the pain doesn't return. Okay? So that's something that you could see. Now, there are some muscular, or they appear to be muscular problems, but they're actually nerve disorders that are changing muscle function. So multiple sclerosis is among those. It can cause spasticity or weakness, pain at the in some areas, all because of the autoimmune condition. Bell's palsy, it appears to be a muscle disorder, but it's actually because of inflammation, and it's affecting the muscles of facial expression. It can have different etiologies. Parkinson's disease can cause bradykinesia or slow movement, tremor, rigidity. It's not actually the muscle that's the problem, it's neurologic that's the problem. And then there can be tics, especially those involved with Tourette syndrome. So repetitive movements. Other types of neuromuscular examples are muscular dystrophy, ALS, and then there can be myopathies or muscle fibers that aren't functioning properly. You can also have neuromuscular junction disease like myasthenia gravis or other types of peripheral nerve disorders. So for myasthenia gravis, for instance, what that is your autoantibodies are affecting the neuromuscular junction. So what you can see is when you're doing, if you're expecting someone to have, if they say they have a lot of weakness, have them track your finger like Tom was mentioning before. And then if you have them look up and they can't hold their gaze up or their eyelid starts to droop down or things like that, that's a telltale sign in a lot of people of myasthenia gravis as well. So the drooping eyelids, weakness that varies throughout the day. If they rest, a lot of times their strength comes back, but if they overuse, it goes away. Trouble swallowing or pronouncing words, anything that's repetitive, they may have trouble with. So I did have a patient who had, she had been diagnosed with possible Bell's palsy, but she also said that she tires easily. She has hoarseness. She has persistent cough. She has weakness intermittently in her hands and her legs. She came to me primarily because she had this tired feeling in her face, or that's how she described it, like a weaker feeling in her face. And she also had some pain associated, which I later decided was basically the muscles trying to compensate. But it interferes with her family time. She also gets headaches as well, which are interfering with lights and sounds. But this started about 10 months ago. And over time, she had seen a neurologist she told me she had seen a neurologist who said that there was no significant findings on MRI, so it must be Bell's palsy. An ENT thought there might be some hearing loss and then chronic rhinosinusitis, but didn't really find a reason why she can't raise her voice as much as she used to be able to, but they had her seeing a speech therapist. Her heart rate was increasing, so she's on propranolol now. But anyway, with her following gaze, trying to look upwards, her gaze fell, and she says during the day her eyebrow might get a little bit more droopy. Now, Bell's palsy doesn't usually change throughout a day, which is what her previous diagnosis was. Long story short, the differential had myasthenia gravis in it. Now, I don't diagnose myasthenia gravis in my practice, but I referred her back. I was like, well, let's get a second opinion. Let's try a different neurologist and see. Because later we found out that I also did some blood work on her, found out that it was an inflammatory condition. Her C-reactive protein was high, which is one of the labs that we sometimes do. But she had been seeing a nurse practitioner at the neurologist office who later we found out thought that she was kind of maybe a little bit of a hypochondriac, exaggerating symptoms or things like that. So once she got in to see the neurologist, she did have myasthenia gravis. So that explains the tired feeling. The reason I bring this up is sometimes people will present with tired, achy muscles, and it might be something else. So just kind of keep your eyes open for what's going on. She had also had an elevated Epworth Sleepiness Scale number, and so we did do a polysomnogram, and she has mild sleep apnea as well. So she's under CPAP and the care of the neurologist now. Another possible muscle disorder that you can find is tardive dyskinesia. So that would be basically little involuntary movements. A lot of times, so that can be caused by long-time use of some antipsychotics or other types of medicines. So there was one patient that she realized that her tongue was protruding forward. And so what we ended up having to do is talk to her. Again, I don't tell people to stop their medications. I'll just tell them, you talk to your physician about this and see if it's possible that this could be related. And for her, her tongue thrust was a tardive dyskinesia from her latuda, because once she stopped it, that went back to normal. So keeping your eyes open to learning about new symptoms may lead to additional diagnoses, so or additional need for referral. So basically, the diagnosis of muscle disorders is you're asking about symptoms, you're looking for signs, so like taut bands, like if you're looking for bruxism, you're looking for wear facets, you're looking for fremitus or mobility. You're asking about comorbidities, because that may actually lead you in a direction that's a little bit different than what you would have originally thought. Like you're asking about sleep disorders, because sometimes that can be related, or it could be a comorbid condition. And then sometimes you do need blood work or additional imaging or referrals for those, especially if you're expecting some type of an autoimmune type of condition. And then I'm not asking you to diagnose all these things, but if there's something that doesn't fit, realize that you can keep looking is the goal there. Okay, so that is all the muscle for this morning. I was also asked to do the intra-articular disorders. So that's what we're going to do next. Does anybody have questions about muscles before we go on to intra-articular? Okay. And I know there's also time at the end when Tom and Sherwin come back for us to do some more questions. But feel free to interrupt me along the way. Yes?
Can you explain the reason why instead of regular muscle day, it refers pain to both sides?
He asked if I could explain why it refers pain to both sides. Again, it's the sensitization of the second order neuron along the way. So central sensitization can refer pain even to distance areas. Yes. Yeah, basically it's just because of how close those nerve fibers are, it's able to sensitize both. Yeah. You're welcome. Yes. Yes. Mm-hmm. Okay. Her question was with the posterior digastric. If you're suspecting a trigger point with referral in that area, what would be the best treatment? And she's right, it would be a very difficult area to do a trigger point injection in. If you were leaning that way, then I would definitely utilize some type of imaging to try to help you get in that area. If you can't use imaging or you don't have that accessible, another good way to try is if you... So, it's an opening muscle, right? So opening activates it, closing helps to kind of loosen it up a little bit. But what you can do is use spray and stretch or some type of a cold application, even ice. I mean, that's fine too. Spray and stretch is just a little spray can that it cools the tissue, and so it's quicker and easier. But ice works just as well. Put ice on there, have them kind of manipulate, move their jaw around to kind of stretch a little bit with that. And then have them practice types of avoidance protocols at home and trying to avoid clenching and things like that, and try to avoid however posturing they might be doing to try to alleviate them from reintroducing that. But you're right, it's a little bit harder to do a trigger point injection there. Yeah.
When you have a patient that is experiencing more pain or we're having this after physical therapy session,
Mm-hmm.
how do you distinguish between having a conversation with the physical therapist to change exercise versus just discontinuing?
Her question there was if someone's having more pain after physical therapy, basically how do you handle it? My advice is to ask the patient, if they're going to physical therapy, to express that to the physical therapist. Let them know that these are becoming more challenging, or they're more painful. Maybe even ask them to show you what that particular physical therapist has them doing. And then maybe it's that, I know even sometimes I give patients home therapies and maybe they're not doing it quite right. And so like I'll have them do little side-to-side lateral motions to try to help get the fluid moving in the joint. And some patients are really moving to one side and holding for a long period of time and stretching and overdoing it. And so sometimes if you just ask them what they're doing and then try to help them to make it within their comfort zones, a lot of times that helps as well. Or if they're being treated for, if they have a lot of inflammation currently and they're trying to do things, then the movement might be exacerbating that inflamed area. So after you kind of get inflammation calmed down, then the physical therapy might be more beneficial at that point. So it's kind of getting the whole picture of what you're trying to treat, and then you can work those pieces together. I think you had a question as well.
Well, I was just wondering, like when you look at, say, what Travell and Simon suggested about treating some of these difficult areas,
Mm-hmm.
and in her text, she suggests that it's important to pay attention to parallel muscles.
Right.
If you're going to try to deal with one specific area, if you can get the patient to actually comply, then you should really be looking at range of motion and strengthening all the parallel muscles.
Yeah.
I wonder how you might approach that with your patient.
So what he's asking is a lot of, if they have symptoms in one muscle, that a lot of times they might, basically, I'm paraphrasing for you, they might be compensating or using other muscles inappropriately as well. So it is important, and that's where physical therapy can be helpful to people, to try to, not that that's the only reason, but that is a reason. They can help them to strengthen their supporting muscles. They can help them to, because a lot of times posture might be a implication or a factor in even the holding of how they hold their jaw can be affected by how they're sitting. And so sitting them to physical therapy and letting them take their look at the whole person and try to help in strengthening or supporting muscles or things like that, then that can be helpful, so that they're not overusing or compensating in the wrong way. Is that helpful?